All right, I think we should get started. So, welcome everyone. I think we got over 35 participants at this Introduction to Arthroplasty Fundamentals course. This is a two-part course. This is the first session. For the next hour and a half, you're going to hear from a number of esteemed faculty from across the country that are members of the Canadian Arthroplasty Society, which is a subspecialty society within the Canadian Orthopedic Association. My name's Dr. Jason Werle. I'm the past president of the Canadian Arthroplasty Society. So this course is intended for residents, and we're going to survey you at the end or after this. You'll get a survey sent to you. Please fill that out. It helps us make these sessions better. Questions are encouraged. We're going to have an interactive session, so there'll be kind of didactic portion of the presentation, and then there'll be question and answer after each presenter. We'll have some cases at the end as well. So please raise your hand or use the chat to ask the questions. This is the agenda for tonight. We're going to hear from Dr. Steve Mann, pre-op considerations. This session is all about primary total hip arthroplasty. Intra-op considerations from Dr. Sharma from the U of C. The current president of the Canadian Arthroplasty Society is Dr. Gavin Wood from McMaster University. He's going to talk about managing the sequelae of pediatric hip conditions. And then Sebastian Rodriguez from the University of Toronto is going to talk about the role of enabling technologies. And then I'll have a few cases at the end. So welcome, everybody, and hope you enjoy the presentations. And I'll hand it over to Dr. Mann.
Great. Thanks so much, Jason. Welcome, everyone. Apologies if my title isn't quite what was there. The objectives I got were what we're going to cover, and I hope you'll find it useful. These are my disclosures, nothing particularly relevant. So we're going to go over indications, biomechanics, biomaterials, and implant design. So just a modest collection of topics for a 10-minute talk. And again, this is meant to be interactive, so please raise your hand or just shout out if you got questions as we go along. So first of all, why do we do hip replacements? And the vast majority of the time, it's for osteoarthritis. This is 2022 data from Canada. You can see 70% of them are for OA, and those remaining arthroplasties, I think a large number of those are actually hemiarthroplasty for acute hip fractures. So by and large, we do hip replacements for osteoarthritis, which is, you may have heard it called wear and tear of the joint. Now, it's probably a little more complicated than that. There's an imbalance between cartilage injury and repair. And for reasons that aren't entirely clear, it happens to some people more than others. It's not directly activity related. But we do know that absolutely it shows a predilection based on sex, so more common in females. And as time marches on, you are more and more likely to have osteoarthritis. We treat this obviously all kinds of ways, both pharmaceutical and non-pharmaceutical, but ultimately the end game for osteoarthritis is surgery. And again, about a relatively even split between hips and knees in Canada, over 100,000 per year, and it only goes up with time as the population gets larger, both individually and collectively, and older. So to talk about hip replacements, I wanted to spend just a couple of minutes and go over the history of it. I am, in fact, a giant nerd, and I think it's important to understand some of this background as we talk about modern hip replacement implants. So back in 1881, Themistocles Gluck started carving hip replacements out of ivory. You can see them there. Then Dr. Smith Peterson in the early 1900s started using this Vitalium glass implant, which you can see in the left hip there. And then finally, the McKee-Farrer prosthesis. So that was the first real foray into metal on metal hip replacements. They worked not too badly, but came with some problems. And then 40 years later, in the grand cycle of orthopedic innovations, we went back to metal on metal and predictably had some of the same problems again. But really, this is what changed everything. So Sir John Charnley is known as the father of the modern hip replacement, and his arthroplasty was revolutionary. So he had a polyethylene cup. He had a metal monoblock stem, monoblock meaning that it's all one piece. So the head and the stem are all together. And then both of these implants were held in place with polymethyl methacrylate bone cements. And this Charnley low friction arthroplasty, as I say, was absolutely revolutionary. It lasted for decades, which was far more than anything else at the time. And Professor Rohrbeck and others have called it the operation of the century. So, what made Charnley's hip replacement work as well as it did? If we're going to talk about biomechanics, we have to have a free body diagram. And so, this is a simplified schematic of the forces that act across the hip joint. So, you've got W, which is the body weight, and A, which is the pull of the abductors. And then counterbalancing them is F, the joint reaction force. And so these three vectors sum to zero. And Charnley recognized that one of the secrets to success in improving longevity of his hip replacement was to minimize F, the joint reaction force. And that was one of the principles of his low friction arthroplasty. And this was because the primary mode of failure of hip replacements was polyethylene wear. So that plastic cup would start to wear out. And as those polyethylene wear debris particles formed, you would get osteolysis because of macrophage activation, and then the implants would get loose and the hip would fail. So Charnley wanted to reduce the force at that interaction between the metal head and the polyethylene cup. And in order to reduce those forces, he set out to reduce the joint reaction force. So wanted to have a smooth head, he had a small head because that was the size of the ball bearings at the railroad factory down the road from where he worked. And he set out to reduce the joint reaction force. So, how did he do that? To answer that, you have to know what the joint reaction force depends on. And so it depends on W and A, right? Because it's related to both the body weight and the pull of the abductors. Those in turn depend on D, which is the moment arm between the center of mass and the center of the femoral head, and the moment arm or the lever arm of the abductors, but primarily on D, if you accept the fact that body weight changing isn't very easy to do reliably. So he wanted to decrease that lever arm or moment arm of the body weight by taking the cup as medially as he possibly could. So that would shorten the length of D and therefore decrease W and decrease F, the joint reaction force. So he reamed all the way medially in his acetabulum as far as he could, actually made a little hole in the inner wall of the pelvis and then laid a little piece of bone across it and cemented his cup in as medially as he could. And that brought the center of the hip as medial as he could get it and decreased the joint reaction force. The downside to doing that is it defunctions your abductors. They're no longer at an optimal tension. And so to overcome that, he did an osteotomy of the trochanter. That was part of his surgical approach. And when he reattached it, he took it more distal on the femur. And by distalizing the trochanter, he stretched the abductors back out to where they were at an optimal working length. And that's what gave him a successful hip. So that's the Charnley low friction arthroplasty. As we said, absolutely revolutionary operation of the century, changed the game when it comes to hip replacement. But you've probably noticed we don't do hips like that anymore. So we've had technological advances since then. And so the question here is, what's the technological advancement that's had the greatest effect on how long hip replacements last nowadays? So you've got four options there. Hopefully everybody can see that and can vote. I don't know, do we get the results live or there we are? Perfect. Excellent. Highly cross-linked poly. Very good. Well done, everybody. So what has changed in the 60, 50 years, 60 years really, since Charnley's low friction arthroplasty? Number one is the polyethylene. It's now highly cross-linked, which makes it far more wear resistant. So the structure of polyethylene, it's these long molecules arranged in long chains. If you blast that polyethylene with radiation, you can change its structure so that you get links that form between the chains. That's called cross-linking. It makes the structure more crystalline and it makes it far, far more resistant to wear. Unfortunately, it also generates free radicals, which can cause oxidative damage, but we've got ways of dealing with that by reheating the poly or putting vitamin E into it. But highly cross-linked poly has been an absolute game changer when it comes to the longevity of hip replacements. And with modern implants, we're routinely seeing survivorship over 90%, well in excess of 20 years. The other thing that's changed is the metallurgy. So now instead of one-piece stems like Charnley was working with, we have modular ones. So the stem is separate from the head. And then we also have cups that aren't just one piece, but they have metal shells with polyethylene liners, which can have different geometries. So they can have lips at the back, or they can have a greater thickness in certain places to lateralize if necessary. So we've got modular components with different options for offset. And also, by and large, especially in North America, we've moved away from cement, and we use uncemented implants, which rely on the bone growing into or onto them. And then finally, we've got the head material. So cobalt chrome is sort of the standard. With certain stems, you can use stainless steel. But ceramic heads have also contributed to the survivorship of hip replacements because ceramic is very smooth, and so it has the lowest incidence of generating wear debris, especially against highly cross-linked poly. So if the ultimate guide or goal of our hip replacement is a stable hip with a restored normal center of rotation and appropriate soft tissue tension, how do we go about doing that? When we think about the implant, we have three variables. There's the height, so that's how deep into the femur the implant is placed, and that mostly has to do with the geometry of both the implant and the femur that you're putting it in. You have the offset, which is the medial lateral distance of the hip. And so you can have standard offset and high offset and extra high offset implants, which will match the geometry of your patient in order to optimize the soft tissue tension and recreate their anatomy. And then you have version, which is the angle that the stem is put into the femur, and then the combination of that with the version or the angle of the acetabular component. You put those two together for a combined version. And again, the goal with all of this is to recreate the patient's anatomy and give them a hip that's stable with soft tissues under the appropriate tension. You got a question, Luca? Oh, no, all good. So early hip replacements had smaller heads, as we said initially, because that was the size of ball bearings that Charnley had access to, and then 28 millimeters. And the concerns there were that you needed to have a minimum thickness of poly so that it didn't wear out quickly, especially before we had highly cross-linked versions, and wanting to beware of higher friction with larger heads because of greater surface area. Now that our materials are better, we've gone up to 32, 36 routinely for most people, and even 40 millimeter heads. So the question is, what is the primary benefit of those larger heads? So again, here's a poll. So feel free to vote. Why are bigger heads beneficial in total hips? There we go. Lower incidence of dislocation. Excellent. Everybody is on it here. So you can see in this schematic here in part A, if you go from a smaller head to a larger head and you keep everything else the same, the thickness of the neck and everything else, you have greater range of motion before the neck will impinge against the edge of the cup. So you can take your hip through a greater range of motion before you lever it out of position. So that is one of the major benefits. The other thing is that you have something called a larger jump distance, and that's the translation of the femoral head. There's a picture of Michael Jordan for those of you who are old enough to remember him. He had great jump distance. But essentially, that jump distance is equivalent to the radius of the femoral head. And so the larger the head, the larger the radius, the further it has to travel before it will pop out of your acetabular component. And there's a more technical picture showing that. And then finally, we've got implant design. So uncemented implants rely on an initial press fit. So you have to wedge them into the femur or into the acetabulum and allow the bone to then grow into or onto them to give you long-term stability. So this requires elasticity. The bone has to be elastic enough to permit you to wedge an implant into position without cracking as you do it, and also have biologic potential to actually heal onto the implant. On the femoral side, these implants can engage in the metaphysis, which is what most modern primary implants do, or down in the diaphysis. The downside to diaphyseal engagement is that you kind of bypass the proximal aspect of the femur, and if it doesn't get loaded, it may melt away over time. That's something called stress shielding. We still do use cemented implants as well, some of us more than others. But there you have interfaces between the bone and the cement and between the cement and the implant. And depending on the design, either the implant will actually slide within the cement mantle or be rigidly bonded to it. This allows you to have even force distribution through the cement, which is good for the health of the bone in the long term. And no biology is maybe a bit of a stretch, but you don't rely on the biology of the bone to heal onto the implant to give you your long-term fixation. And then what all this boils down to is excellent survivorship. So you can see the green line here. This is from the Australian National Registry. For hip replacements done for osteoarthritis out beyond 22 years, you've got survivorship that is greater than 90%. Your failure rate is under 10%. And that's really pretty remarkable. You can see slightly different for these other diagnoses, but the vast majority of hips with modern implants have a better than 90% chance of lasting over 20 years, which is pretty remarkable and also really great for our patients. So in summary, in Canada, we do over 50,000 total hips a year, mostly for arthritis. The goal is a stable and pain-free joint, and fortunately, the vast majority of patients experience that and have excellent longevity. So thanks very much. I think I was almost on time and
Yeah, it's
happy to
perfect.
take questions now.
Yeah, thanks. Thanks, Dr. Mann. Questions from the audience, either in the chat or raise your hand.
The biomechanics talk, I bored them all already.
No, you explained it so well. There you go. Okay, well, if there aren't any questions, I don't see anything in the chat, then why don't we have Dr. Sharma give his talk on intra-op and post-op considerations.
Sounds great. Just about to share. Can you see that?
Yep, looks good.
Awesome. All right. First of all, thank you, Dr. Werle, for inviting me to give this talk and be part of this. It's great. Dr. Mann, I can say that I got both your questions right. I gave myself a pat on the back, so I was pretty happy. I'm sure Dr. Rodriguez didn't get any of those right, so pretty proud of
Well done.
myself. Yeah. I'm going to jump into this talk, talking about intraoperative and postoperative considerations. So here's the agenda that I was given. Quite a bit of things to cover, but hopefully we'll get through it in about 10 minutes as kind of an overview of each of these topics. So before I jump into that, quick question, poll the audience. In terms of what anesthesia type is used at your site for same-day rapid discharge total hip replacements? So 4 options there: spinal, with or without sedation, general, epidural, or combination. All right, spinal. Perfect. Perfect. And then I'm going to go on to the next question. Oh. Which total hip arthroplasty approach are you mainly taught in your training? So posterior, lateral, anterior, superpath, or other types of approaches? Yeah, it's kind of even between posterior, lateral, and a little bit less than anterior. Excellent. Okay. So in terms of anesthesia type, I'm going to jump into it. So 3 broad methods, and we saw that in the poll as well, in terms of spinal being the most. But there's generals, spinals, and epidurals, and I'll quickly just kind of go through some of the advantages and disadvantages of each of them. So in terms of a general anesthetic, it's rapid, just put the patient to sleep, allows for complete muscle relaxation. Good for longer procedures. Those procedures you can't predict the time. There's no waiting for motor resolution at the end of the case. Patient's awake and you can have motor function back. Disadvantages: higher nausea, vomiting, throat irritation, cough. Blood loss can be higher because it doesn't allow for some hypotension, and some cognitive issues and delirium can also occur. So those are the disadvantages. In terms of a spinal anesthetic, as we saw in that poll, lots of good advantages. Fast onset, reduces blood loss with hypotension, better initial pain control, reduces nausea, vomiting. Some of the disadvantages: it cannot be topped up. So if you cannot predict the time, sometimes that could be an issue. You may have to convert to a general. And then they can have some spinal headaches. Typically, spinal anesthetic is the gold standard. In terms of epidural anesthesia, it's another type, similar to spinal, with some added benefits. Those benefits are immediate resolution once you turn off the epidural. Ideal for rapid discharge. Can be topped up if it's a longer procedure, but the disadvantages are it's slower to insert, to titrate, and it takes a bit longer overall. and there can have some catheter-related complications. In terms of surgical approaches, this is not a talk on surgical approaches, but there's a whole type of different ways. The general broad category ways of the standard approaches like posterior and lateral, we saw that in our poll as well. And other types of approaches are some of the minimally invasive, so mini posterior, mini anterior, mini laterals. Some approaches have some IT band sparing, for example, the direct superior approach. Some have the IT band and posterior capsule sparing, which is the anterior approach. And typically, as we saw in the poll, these are kind of the three top approaches that are being used. So jumping on to managing intraoperative fractures, some of the basic principles of intraoperative fractures. This is as you're doing the procedure, you notice that there is something wrong. So the principles are identify the fracture, increase your exposure to understand the extent of the fracture, and then decide on what the next steps to do during the case. This could be both on the acetabular or the femoral side. So I'll start off with the femoral side. This is a modified Vancouver classification for intraoperative fractures. So these are typically classified into three different categories: metaphyseal, diaphyseal, and then distal. So in terms of metaphyseal, there's three different types, and each of these categories in terms of metaphyseal and diaphyseal are three different types. Those are perforations, cracks, and then completely displaced. So if there's a perforation, you can just reposition as long as it's stable, and you can bone graft. If it's a crack, you can put a cable. If it's displaced, you may need a longer stem. Diaphyseal fractures, similar. They could be perforations, cracks, or completely displaced, and you'd have to fix the fracture and then bypass it. Distal to it, these are fractures that you have to treat with an open reduction internal fixation of some sort, some combination of cables, plates, and the combinations of thereof. So here's kind of the Vancouver modified classification for intraoperative fractures. So again, the type A's are all metaphyseal, cortical perforations where you can bone graft. You can use the acetabulum reamings, that is the states there. There are the non-displaced cracks, so you can put a cerclage cable before putting your final stem. Then you can have the displaced ones, and so you have to fix them with cables and then use a distal diaphyseal fitting stem to bypass that area that's displaced. Type B's are more in the diaphysis, so they can be a cortical perforation. In these cases, you want to bypass that stressorizer or that perforation, and you can use strut allograft or some kind of bone graft in the area where the perforation was located. Non-displaced cracks, you can cerclage wire and bypass it. And then the displaced ones where you may need to augment it with some cables or some plates in order to help stabilize before bypassing it. And the type C's are distal to the tip of the stem, requiring open reduction internal fixation. On the acetabular side, you can also get some fractures, and these are typically categorized within recognized, non-recognized, and then pelvic discontinuity. So if you recognize it during the case and it's stable, you can treat it with adding some supplemental screws and then protect weight bearing. If you recognize it and it's unstable, you have to take the cup out and revise it to a multi-hole cup and add some extra screws and some fixation. If it's not recognized and it's stable, you can leave it alone and treat it post-operatively. Or if it's unstable, then you have to take it back for a revision. And then the pelvic discontinuities, you're going to have to increase to a cup cage or some other kind of construct to gain stability. So in terms of blood loss and prevention, this is four of the main categories. The most important is tranexamic acid. It's well known to help decrease blood transfusions, works effectively, could be used through IV, oral, topical. As long as you give it, and you should give it, it's very useful. Regional anesthesia, just like I mentioned, spinal anesthetics reduce blood pressure, so hypotension, which allows reduction in bleeding. You can use a cell saver, especially if you're predicting high blood loss and more complex revision type cases. You can use this blood and give it back to the patient. And then bipolar sealers, these are like the aqua mantis, rarely used due to extremely high cost. In terms of infection prophylaxis, I divided up into preoperative, intraoperative, and postoperative considerations. So preoperative is decolonization, so things like chlorhexidine sponges on the skin, nasal decolonization. Treating existing infections, so UTIs, dental, or any other type of infection that could be identified before surgery. And then comorbidity management. This is a big area, extremely important to optimize the patient themselves. So things like smoking, diabetes, malnutrition, obesity, rheumatoid, transplant patients. These are patients at high risk of infection and is trying to maximize them beforehand for optimization to help decrease postoperative infections. In terms of intraoperative, skin preparation, so chlorhexidine has been shown better than iodine. Laminar airflow within the operating room. Prophylactic antibiotics essential within 60 minutes of the incision. Changing gloves, doubling up the gloves has also been shown to be important. Iodine irrigation and diluted intraosseous vancomycin has also been talked about more recently. In terms of postoperative, postoperative antibiotic dosing and then negative pressure dressings in the obese patients can help decrease infections. Thromboembolism. So this is divided up into three different areas: pharmacological, mechanical, and then early mobilization. In terms of pharmacological, typically 35 days is what we aim for, and there's lots of studies that are being done in this area. Some are very exciting. So the EPCAT-3, looking at only aspirin. I'm very excited to see what these results will show. The recruitment has been completed, and we're just waiting for the results. And then there is some kind of DOAC, so it could be a rivaroxaban, a pixaban for 5 days followed by aspirin. So this is the EPCAT-2, shown to be very effective. And then there's the DOACs only, those or the low molecular weight heparins on patients who are at higher risk, so previous blood clots, cancer, and other such patients who are at high risk for the entirety of time of the 35 days. Mechanical, these are categorized into intermittent pneumatic compression, TED stockings, and some foot pumps, and also early mobilization. So you notice that we get patients up earlier and get them moving quicker, so within 4 to 6 hours, maximizing hydration and also ankle moving and the pumping of the ankles. So in summary, I rapidly went through kind of anesthesia types, surgical approaches, managing intraoperative fractures, blood loss and prevention, infection prophylaxis, and thromboembolism prophylaxis. I think I hit just about 10 minutes.
That's great. Thank you very much, Raj. Any questions from the audience? I don't see any, but I'm gonna have to start asking some questions. Okay, Raj, can you talk a little bit about preoperative antibiotic choice and timing?
Yeah, so within 60 minutes, typically speaking, cefazolin, 2 grams IV. Those who don't have an anaphylactic reaction to penicillin and prove an anaphylactic reaction. I think there's a lot of people say they're allergic to penicillin, but they may have had a rash when they were a child many years ago due to the additives. So those don't count. And still, the mainstay of treatment is to give cefazolin to those patients. Those who are at high risk of anaphylaxis or true anaphylaxis to cefazolin, two choices are the clindamycin 600 Vanco. And so benefits and downsides to both. You can give the Vanco. It takes a little bit longer to infuse. So depending on your timing, the important thing is to have it into the patient before cutting skin. And yeah, that's probably the most important. I see a question there about how are you dosing tranexamic acid. So it's I didn't go into that in too much depth because there's so much variety in terms of what to do. Some locations give a gram pre-op and a gram at the end of the case IV. Our hospital, not facilities, our hospital specifically gives a gram beforehand, and we typically put a topical gram as well at the end of the case. So we do a combination of both. And then I sometimes, depends on high risk patients, I'd also give 1500 orally before they go home. So there's a variety of it out there. And I think the dosing, it doesn't matter as much as the importance of giving it or how you give it.
Great, thanks. Maybe one other question. Some of the residents may see people wearing exhaust suits in the OR. Can you talk about what's that intended to do, and is it helpful?
Yeah. So as you notice, I did avoid that in the intraoperative part because it's helpful for safety of yourself during the operation more than infection prophylaxis or to reduce infection. So it hasn't really shown to reduce infection, but worn mainly for your own protection of flying objects.
Great. Thanks very much. All right, we'll move on to Dr. Gavin Wood, who's going to talk about managing the sequelae of pediatric hip conditions. Thanks, Gavin.
You can see my screen okay?
Yep, looks good.
Okay, so thank you, Jason. So the objectives of this talk are really to recognize the common adult sequelae of those pediatric hip conditions and to understand how childhood deformity leads to secondary osteoarthritis in adulthood, and some of the nuances around performing total hip replacement in such cases. And what I want you to keep in mind is your aim is really to restore the natural soft tissue balance of the hip, which Steve alluded to, and try and restore the center of rotation of the hip. The hip never forgets its childhood, and the kind of conditions we're going to talk about are Perthes, developmental dysplasia of the hip, slipped capital femoral epiphysis, and often these conditions can lead to surgeries from your pediatric colleagues, which resulted in either osteotomies, which may also mean that there's retained hardware. And whether there was surgery or no surgery, you often have to with multiplanar bony abnormalities and abnormal hip biomechanics, all of which have led to secondary osteoarthritis of the hip and arthritis in young adults. So, SCFE or slipped capital femoral epiphysis, the milder ones that often go unrecognized will lead to a posterior slip, and this can lead to loss of the head neck offset. And this is what we've identified now as the adult CAM or femoral acetabular impingement, and where you have this kind of large, odd-shaped femoral head in a small socket. And this impingement can then lead to labral tears, cartilage delamination, and the subsequent development of early arthritis, mainly in young adult males. And this is the so-called pistol grip deformity, and this is why this has been described as such. You can see the old-fashioned pistol on your right-hand side. And these patients often have reduced flexion and internal rotation. So the concerns here when doing such hip replacements are the large offset, so the center of rotation of the head out towards the tip of the GT or the anatomical axis of the femur. And this could be problematic because it can lead to metaphyseal-diaphyseal mismatch. And what this means is that the metaphyseal region is large and you'll need a large offset. However, because they're young adult males, they often have very good thick cortices and you have a very tight, narrow diaphyseal or femoral canal. And when you go up with cementless stems, you go up in offset, but often that small restricted internal diaphyseal canal can restrict you going up in stem size. And so obtaining the large offset required can often be difficult. Perthes, or AVN of the femoral head in childhood, osteonecrosis of the femoral head, as you can see here on the right hip, will often lead to loss of sphericity of the femoral head and failure of the growth plate. And that failure of the growth plate, an aspheric large femoral head, also known as coxa magna, can lead to an incongruent hip joint. And then the abnormal forces going through the hip joint on the cartilage, delamination, and high forces is what leads to secondary osteoarthritis. And they often talk about hinge abduction as well in such cases. And that's what they try to prevent in childhood, but it can progress to developing in adulthood. And then you have a short neck or coxa breva with subsequent GT overgrowth, which can cause impingement, but also abductor deficiency and leg length discrepancy, as you can note here in this X-ray. So these patients will often have a stiff, painful hip, and they'll be Trendelenburg positive, have a leg length discrepancy with limited abduction and flexion. And in this case, this individual had bilateral Perthes disease as a child. And so the problem here doing a hip replacement is that you've got potentially GT impingement, which can lead to dislocation. You try to restore the leg length and offset for what a natural hip would be. And on the acetabular side, it can often lead to a large satellite dish type acetabulum due to the incongruency and failure of the acetabulum to develop in childhood. And when that happens, you have to be aware of potentially reduced bone stock, particularly in the anterior column of the acetabulum. And you can see here too that this is mainly an inlet type view of the pelvis with the hips in AP, which means that they've obviously got some kind of fixed flexion deformity and the pelvis is tilted. And so you have capsular abnormalities that you also have to deal with. So the key points here is that you'll often have to do a full capsulotomy to try and restore the leg length, get rid of the fixed flexion deformities. You want to improve the offset. Here, a cement stem was used to try and address the metaphyseal-diaphyseal mismatch, and the acetabulum or the cups were medialized to try and get past that rather abnormal satellite dish type acetabulum. Then we have developmental dysplasia of the hip, which essentially from childhood, either at birth or if it's gone unrecognized, can lead to failure of the head to develop, or the head is not contained within the acetabulum. And from your pediatric lectures, I'm sure you remember this can lead to a shallow acetabulum and often undercoverage of the femoral head. This undercoverage of the femoral head can lead to large labrum and then labral overload with edge loading, and then it can cause tearing of the labrum, tearing or delamination again of the cartilage, and secondary osteoarthritis at a young age. This case, in particular on the right side, is a little bit milder, and some surgery has been done on the acetabulum to try and give some coverage, obviously, and an osteotomy with retained metal work. And on the left side, essentially a femoral head that is abnormally developed and in a false acetabulum and not within the true acetabulum. And these patients are often of pain, leg length discrepancy, weak abduction because of the disadvantage of the abductors, but they often have excessive range of motion as a young adult with potentially because of the instability, but then that reduces as they get older. And they often have excessive femoral neck valgus, as you can see on the left hip here. And often the femoral neck has got excessive anteversion. So you have to keep that in mind when considering hip replacement and placing a stem in that femur. And these femurs also are traditionally known to have a very small or underdeveloped intramedullary femoral canal. So when you're doing a hip replacement, you want to restore leg length. Sometimes they're so short, if you try to bring the hip down, that can lead to excessive lengthening of the femur. And come with that is problems with regards to the sciatic nerve, which can then be put on stretch and lead to foot drop and weakness. As I mentioned, you also want to try and correct the anteversion of the femoral neck, so you sometimes have to retrovert these stems. And then you want to restore the offset. And there's often acetabular deficiency. So if you look here and you're trying to bring the cup down to its normal position on the true floor next to the teardrop, you're going to have quite sufficient or deficient, sorry, superior bone stock. And then you might have instability of the cup or instability of the hip. So the key points to consider, first of all, on the cup side is you want to medialize the cup, try and get some bony superior coverage. That might require superior bone graft, as was done in this case. You want to try and posteriorize the cup. There's often excessive bone in the posterior column because the anterior column is often deficient. And don't be led astray by that false acetabulum superiorly when you're reaming. On the stem side, as I said, you want to try and reduce the anteversion. If there's a excessive anteversion, as well as you're going to have to lengthen the femur, you might need to do a subtroch osteotomy, remove a section of bone, and you can do a derotation and shortening osteotomy at the same time. And always keep in mind that you've got a smaller femoral canal. It's always important to template these cases. As I mentioned, with any of these hip conditions, they may have had previous osteotomies. In this case, on the right hip, they've had a previous femoral osteotomy, which led to significant abnormality on the femoral side. So you'll often have a distorted IM femoral canal. There's a residual deformity. Obviously, there's no retained metal work in this case. Often, if there's a previous acetabular osteotomy, this can affect the true version of the acetabulum as well as bone stock. And I often find in these cases, whether it's an acetabular or femoral osteotomy, obtaining a 3D CT reconstruction scan can often be helpful in understanding any biplanar or triplanar deformity that may have occurred. And then you have to then consider whether you have to correct that deformity or adapt that deformity with your implants. So a CT scan was done in this gentleman's case. And on this occasion, a correctional osteotomy was performed to realign the proximal femur to allow a stem to go down, and then the cup was put into position. Here, a derotation osteotomy was also done, as well as shortening, and similar to DDH case, and that was held by a 1/3 tubular plate. So retained metalwork, as was shown in a previous case. So you have to first think, what was the purpose of the original surgery? What were they trying to do? At what age was the surgery performed? And what device was used? Because that'll give you an idea as to how to get this metalwork out and whether you need to remove the metalwork, whether you can retain it, how much do you remove? So in this case, can we just take out the screws and you can get a stem down there, or does the whole plate have to come out? And should this be done at the same time as the hip replacement, or should it be done as a two-stage where the metalwork's removed, you allow the patient to heal, and then you come back for a second operation? You have to consider stress risers, so weakness in the bone, which may then propagate into fracture at any point. So in summary, young patients, they're more active and they live longer. So you have to consider that when you're choosing your implant for longevity of that implant and the surgery to be performed. The anatomy is often distorted. These are complex cases. They have a higher complication rate, and the need to plan surgery is extremely important. And templating and CT scans are strongly advised. And you have to think of the problem that is in front of you. If you don't think of the problem, you won't recognize the problem. And if you don't recognize the problem, then you won't deal with the problem. And for me, that's a big problem. These are not routine primary total hips. And just lastly, a quick plug for an arthroplasty course we're trying to do in Hamilton this summer. There'll be more information to follow. However, if you want to email that address, then more information will be nearer the time. And I also have some questions just to check to see if you were paying attention. You can put up the polls. So an X-ray, which feature is most consistent with adult dysplasia? A medialized femoral head, increased offset, a shallow acetabulum with increased tonus angle, or protrusio? Excellent. Next question. Which of the following is a typical adult sequelae of Perthes disease? Coxa valga, leg lengthening, trochanteric overgrowth, or increased femoral version? Trochanteric overgrowth. Increased femoral version is associated with DDH. Leg lengthening, they're all pretty short, so it's not that one. And coxa valga is the high valgus, also associated with DDH. A 35-year-old presents with groin pain and reduced internal rotation. X-ray shows a pistol grip deformity. What is the most likely underlying childhood condition? Perthes, Skiffy, DDH, or infection? Perfect. Back to grade A.
Great. Thanks.
Thank you, Jason.
Thanks, Gavin. Great summary. Any questions from the audience? Quiet bunch tonight. I do have one question for you, Gavin. So, since many of us train the screening ultrasound of neonate hips has kind of come into being, and that visualization is better and standards have improved. Do you think that's going to improve the chance of us not seeing as many late presentation DDHs that need big reconstructions?
Oh, for sure. When you think between us in Canada, how many times we see, DDH or really severe DDH. It's few and far between these days. And you often think, when did I last see one? And you will see milder versions, but not the more severe ones. And then I have to say that when you go down and do a lot of these missions to Central America where they don't have screening, the number of DDH cases, severe DDH, and the pediatric sequelae is very, very common. And so clearly, um, ultrasound screening of babies in the Western world has dramatically reduced the sequelae of DDH for sure.
Great. Thanks. There's a question in the chat. Um, in adult DDH undergoing total hip arthroplasty, where do you seat the cup, the true or the false acetabulum?
True, 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 true.
Okay, great. Thanks. So our next speaker is Dr. Sebastian Rodriguez. There's another question just before we go ahead. DDH, what do you use for bone graft?
And try and DDH you can use the patient's own bone because you've got the femoral head that you've just removed. And if you're doing a subtroch osteotomy, you've also got a napkin ring of bone that you can also use as well. I generally don't use the napkin ring technique, but I will use the femoral head autograft if I have to do a subtroch osteotomy to place at the osteotomy site.
Great, thank you. All right, Sebastian, he's going to talk about the role of enabling technologies in primary total hip arthroplasty. Thanks, Seb.
You guys can hear me? You can see my screen. We're all good?
Yeah, we're all good. Thanks.
Awesome. So thanks for having me, Jason, and thanks to our other faculty for those great talks. And so I'm going to talk to you about enabling technology. So hopefully this is the cooler version of everything you just heard tonight. I also think these talks are great because you get to hear so many different faculty from different places offering different opinions. So in terms of financial disclosures, I do receive financial honoraria from Zimmer, Stryker, IntelliJoint, Mizuno, and Seamless, and Precision OS, and at least 3 or 4 of those companies are technology companies. So everything in my talk is theoretically biased, but I'll present it anyway. But just so we're all full disclosure here. So first poll of the evening is, in my current training, I have seen or used additional technologies during hip replacement surgery. 100% of the time, 50% of the time, a tiny fraction for some cases, or I don't even know what you're talking about. Sure. All right. So the vast majority of people have had maybe a little bit of exposure, but not really. My next question would be related directly to this. As residents, when you're training with your staff, if they were offered additional hip technology, would they love to use it? Would love to use it but don't have access to it, or they actually use it, would love to use it but don't have access. They're aware of it, but they say they don't need it because they're just that good. Or again, they don't even have any idea of what I'm talking about. All right, so at least half of you are working with people that would like to have access to technology. So as residents, I'd also tell you that if you aren't seeing some of this stuff at some point during your training and you have an interest in it, you should make your way to a center where you can actually see some of that, because I think this is really the future, whether you believe in it or not. So why do we even have to talk about technology in total hip? I think you've just heard some great talks that show this is a historic operation with a high success rate. And we've heard a lot of talk about sort of, how do we deal with that success? And it's dependent on a couple of key things. Your cup positioning, your leg length, and your offset. These are all things that are hammered into you as a resident, in your pre-surgical plan. And it's important to understand what those things are. Your anteversion angle, the abduction angle when you're talking about the cup, and then understanding what the center of rotation is natively of the hip, where you want to restore it to, because that, dictates things like offset. And of course, with that, you can talk about leg length. So technology aims to improve the reproducibility and reduce outliers, both of x-rays, but also clinically of some patients. So you can have a great pre-surgical plan, like you can see here on the left, and really the goal of that, this is just a computerized template. So even this is, to a degree, use of some technology, though not what we're getting at today. And so this is your outcome. And you really want to be able to have reproducible means of doing that. And if you're just that good a surgeon that every single time you can do that manually, that is very good. But I think multiple papers have shown that as good as expert surgeons think they are, we're not always hitting the targets we want to hit. And what do we do currently? We use conventional instrumentation, and this is great. This is low cost. This is widely adopted. Much of it hasn't changed for several decades. It has, excellent results in experienced hands. However, the bulk of all of these sort of tools that you will see, they rely on estimations and assumptions of body positioning, that the lateral position is still in the lateral position, and that visually you can assess what 45 degrees is, what 40 degrees is, what 20 degrees is just with your eyes. And if we look at the cup generally, we are taught if you're looking at it conventionally, and regardless of surgical approach, people talk to you about visual cues. The transverse acetabular ligament, where that lies, that should dictate your anteversion and how can you assess anterior cup coverage. As you can see here, there's your transverse acetabular ligament, nicely in parallel with the inferior portion of the cup, and gauging where your cup is when you're placing this. In terms of leg length and offset, there's external jigs that you can use. Sorry, this is for the cup here. Again, you may have seen these sort of helicopter handles that you put on top of a cup inserter. If the patient's in the lateral position, you're just judging to see is that flat to the floor or not, and that's 40 degrees or 45 degrees. And these are just examples of the manual jigs. When you're talking about the femur, when you're talking about leg length and offset, often people feel the malleoli through the drapes and feel like, well, they're pretty close together, or they're within one thumb, width apart. This is an external jig that can be used in. Some people have these conventional jigs here at Mount Sinai in Toronto. They use something like this where they hammer it into the pelvis and, figure out where the leg length and offset is by making a dot on the femur and reproducibly sort of measuring that once you've put your trial components in. People have gone so far as to use a suture basically and go over a cautery spot. So these are pretty crude conventional instruments that, albeit work in very experienced hands. But unfortunately with this, errors can occur. A lot of this relies on the pelvis not moving throughout surgery. And as we know, the pelvis can shift quite a bit when you're impacting a cup or reducing a hip or dislocating a hip. Leg length is very difficult to assess in the lateral position. If you're just feeling knees or malleoli. And offset is very difficult to actually quantify without measuring. Just it'll be a feel of the soft tissues over the greater trochanter, but you can't really quantify how much you have increased or decreased someone's offset. So again, all these measures that we meticulously lay out on our X-rays and pre-surgical plans, are prone to potential error in terms of increasing leg length or increasing offset, unknowingly or unwillingly in many patients. So when we talk about assistive technologies, what are we really talking about? And two broad categories would be something like image-based or imageless. And this basically dictates if you have to require to get specialized X-rays or 3D imaging like CTs and MRIs to plan the case beforehand, or if you can just use bony landmarks intraoperatively to be able to assess to be able to register the technology. So if it's imageless, usually intraoperative landmarking is enough just to register the bone. And then the other two main categories, if you will, of assistive technology would be something like navigation versus robotics. Navigation is really giving you accurate position based on some landmarks, and you can quantify those numbers, whereas robotics speaks to sort of a machine-controlled arm, which can either guide or make cuts for you in either hip or knee arthroplasty. And this can also help in the reaming of the acetabulum. So if we first talk about computer navigation, this involves, registering the bony landmarks before you make any resections. Typical landmarks for something like this would be the ASIS, the pubic symphysis, and on the femoral side, it's a fixed point that you can reproducibly get to once you have your surgical exposure, generally on your greater trochanter. Now, once you've registered these landmarks and you've anchored something to the bone, namely usually the pelvis, if the pelvis rolls or moves, you're going to have consistent positioning, which allows you to get real-time feedback, which is quite accurate. The other thing is if you're using the femur as a fixed position as well, you can get leg length and offset feedback. So overall, this improves the consistency of your component positioning and allows you to execute the surgical plan that you've set out to do, but doesn't limit you. So here's an example, full disclosure. This is a company that we use, Intelligent Navigation. They're a Canadian company. I will decrease the volume there, but basically what it does is it just shows you how this is an example of how multiple computer platforms would be in terms of navigation. You have to create a fixed point on the actual pelvis. So this will involve bony anchors into the pelvis. In this case here, you're mounting a camera, which will allow you to visually look across to the hip. You register landmarks, like I said, on the pubic symphysis, on the ASIS, and that gives you a pelvic plane from which you can then register cup position and modify that intraoperatively despite the patient moving. So this gives you much more accurate, cup positioning reproducibly. Um, Again, if we see this through here, once you put in your femoral stem, there's a little disc you put on the femur. They've traced out beforehand. And again, once you reduce the hip, you can determine what your leg length and offset are. The benefit of many of these companies is that they're open platform in terms of computer navigation. So if you're a Synthes user, a DePuy user, a Stryker user, you can use one of these assistive type technologies. Like I said, that was one example of a company. There are many companies. Some of them require preoperative CT scan. With that, you can scan that QR code and basically have a virtual intraoperative view of the pelvis, which allows you to accurately put your cup position where you want. And then there's fluoroscopic aids as well. So these are fluoroscopic aids that can be used with AI, basically to help guide where your cup is going. And under image guidance, it can actually give you real-time feedback, not just an idea of the X-ray, but it'll tell you real numbers in terms of cup anteversion and inclination, and even leg length and offset. So that's computer navigation. In terms of robotic assisted surgery, what I love about robots is makes me think about this. So, being a bit of a nerd, you remember Star Wars, this epic scene with Luke and Darth Vader, which then led to this. And, I don't know how old this is now at this point, 40 years old, but if you think about this, this is what we think about when we think about robotic surgery is a robot autonomously doing a procedure with high degree of accuracy without even involving a human. So while we think like things like this are coming, this isn't necessarily what's going on. And robotic assistance really implies that you have surgical accuracy via robotic control. As of now, there are no autonomous robots for hip replacement surgery. There are autonomous robots coming out for knee surgery, and I think hip replacement is not going to be far behind at some point. What I mean by autonomous is that you will prepare bone, but you won't actually have to guide a robotic arm to do it. It'll be the robot actually performing that surgery. In the case of most robots, you again have image-based surgical planning or image lifts. If you start to use CT-based images, you can really get a high fidelity and reproducibility of component position. It also, this is an example of a knee, but in hip as well, you can have, reproducibility of component positioning that you otherwise would never have had with just looking at X-rays. So again, a quick example here of robotic assisted surgery. And again, this is full disclosure. This is a Stryker Mako robot, which was really the first surgical robot to be introduced in hip surgery at a main level. And again, this requires the use of a CT scan ahead of time. Once you have a CT scan, you have, again, two pieces to the robot. You have a camera, both in images that are allowing you to look across, and then you actually have the robotic arm. So here you have your preoperative CT scan, which is compiled. You, as the surgeon, can now plan your surgery ahead of time with, oh, with a great degree of accuracy. So you can see here, you have a preoperative case. You're preoperatively templating your femur ahead of time to help determine the sizing. So intraoperatively, you have to take bony landmarks on both the femur and the acetabulum to be able to teach the robot what that CT scan is on the body in real space. With that, you can now template a neck cut. So this gives you a high degree of accuracy as opposed to just using your finger or one finger above the lesser trochanter, which is how I was taught to do hip replacement. This really allows you to dial in customization for patients. You can even assess anteversion on the femoral stem, and knowing that, play with your anteversion on the cup. So again, a lot of these robotic platforms require registration. So that does take time ahead of time. You have to teach the robot intraoperatively what you're looking at in terms of the acetabulum or the femur. And then once you have all those data points, you can then use it to use the robot manually. So in this case here, the robotic arm is guiding you, and you still ultimately pull the trigger and can ream the acetabulum, but it's controlling how far you can ream and to the depth and position of which you're reaming. So the nice thing about this is when you're placing a cup, it's highly accurate of where you want to go. That prepared bone is within, a millimeter of what you wanted on your surgical plan. You even have a robotic arm holding your cup as you're impacting it, so it's impacting it just in that angle that you want. And again, all these angles can be customized to whatever it is that you desire, and to the degree and to the millimeter. So this degree of accuracy is really not able to be achieved with just the human eye. Again, that was an example of a Stryker robot. As you can tell, there are many different surgical robots across medicine, and especially in orthopedics now, every major company has some robotic or navigation solution that you can use. I think the takeaways I want you to take from this talk is that there's a lot of new ways to do things and a lot of different companies and a lot of opportunities for you to learn them. Technology doesn't replace judgment. It makes you the surgeon better though. So if you think of the robot or navigation as a surgical tool or instrument or a guide, you wouldn't do a knee replacement without a guide. You wouldn't do a hip replacement without a preoperative X-ray and a template. This is just the next iteration and next level of that. As you talk or as you hear a lot of these robotic and navigation talks, you're going to hear about accuracy, precision, and reproducibility. And these technologies give you both highly accurate, highly precise, and allow you to hit your surgical plan every time. So, in terms of evidence in hip replacement, because hip replacement has been so successful and because our metrics of assessing patients are pretty basic, if you look at our outpatient outcome scores, robotics and navigation have never shown to have a clinically superior outcome. However, they are definitely better in terms of reproducibly getting radiographs that you're happy with. So in terms of looking at x-rays and saying that cup was a little too vertical or it made this patient 2 centimeters too long, these are things that could be issues down the road or present problems. But yeah, every time you use some sort of additional navigation or technology or robotic, you're really not going to have these outliers on x-ray anymore. In terms of long-term and term outcomes, I think eventually we're going to show that the better we're able to position components, assess things like impingement, and for component wear, I think now that we're demanding more of our implants, I think we'll have better outcomes as we start to use some of these technologies. But as I mentioned, hip replacement is generally so successful, being called the operation of the century, that it's hard to really get much better with some of the metrics that we're using. There's a huge argument of cost versus value when we talk about some of these technologies. Every time you use a robot or assisted technology, there's a capital cost to that. You have to pay for the robot to be in the room or the sets to use, and a disposable cost. The extra plastic on that robotic arm or drapes or the pins that we use are all disposables. If you do high volume surgery, you can drive down some of these costs. If you're efficient and fast with them, you can drive down some of these costs. But at the end of the day, there is a cost to some of these technologies, and you have to be aware of that wherever you're working. I'd also mention that's why probably half the surgeons that we mentioned on this poll think that they want to use technology, are interested in it, but sometimes the limitation isn't because the surgeon doesn't want to or doesn't have access. That the access is really controlled by money and by the hospital. So, last question. If I was given the chance, when I enter practice, would I like to use additional technologies for hip replacement surgery? 100%, 50%, tiny fraction, or I don't know what you're talking about, which means I wasn't very good at presenting this. All right, so yeah, I'd say at least three-quarters of you are at least interested in using it a lot of the time, and I think that's the right answer because these technologies aren't going away. So the better you can get exposed to them early on and have interest in them, I think it may not be this iteration that's the next thing, but it'll be something that builds on these platforms and ideas. So thank you very much. Any questions?
Thanks, Seb. Questions from the audience?
That riveting. Well, it's bedtime.
So Seb, do you think, I mean, obviously there's going to be continued adoption of assistive technologies, including robotics. Do you foresee a day when it'll become the new standard of care at some point?
100%. I mean, I think
Mhm.
all of these things to think what we're doing for the majority of us, the majority of our careers, myself included, we're doing the same operation that was invented like 30, 40 years ago, right? And every other technical process in the world that involves manufacturing, because at the end of the day, we're a manufacturing plant. We're building things. It involves technology and robotics, right? Robotics and technology and AI have penetrated every major market segment. Medicine is lagging behind, and if you can't mistake yourself, like we are basically building widgets and we can customize that and make it an art form and very romantic from the old days. But at the end of the day, it'll be sleeker, more efficient, better with better outcomes, probably at some point, maybe not now, you can argue, but with technology.
Seb,
Great.
Yes, sir.
Mhm.
I think I'd agree with you with the hip. I think we know what we want to do in center of rotation and offset and leg length, and computers or robots can help us kind of reproduce that. But I think I think we still have some way to go to kind of figure out where we're putting the knee replacement, right? There's all these various different types of alignments and kinematic, restricted kinematic. And so the robot will only put the implant where we kind of think it's got to go. And I don't think we've quite answered that question yet. Would you agree or
I would
disagree?
disagree. I'd actually think it's more important even in knees than in hips, because I agree everything you said about hips. But with knees, until you use a robot in a knee replacement and you realize how you can change that component position and how much it affects range of motion and how much distalization of the femur versus, a little varus on the tibia or slope, like you don't even understand what you don't know until you see the robot. And then you can have a whole new appreciation. And those alignment strategies that you talked about, you can't do half of them unless you have additional technologies. And there's a lot of strong evidence coming out about more kinematically aligned knees, whichever alphabet soup you want to use to describe that, generally do a bit better in terms of less soft tissue releases. And I think we're just the tip of the iceberg, but I think that iceberg is immense in knee replacement, which I think is going to be hugely technology dependent to be able to reproduce that. But that's, again, my opinion as a biased spokesperson of those technologies.
Yeah,
But
I
Raj or
think there's
Jason, do you guys think about, I mean, do you guys have any thoughts on that?
Yeah, I think, with the introduction of a lot of these technologies and the massive amount of data that we're going to acquire on patient populations, we're going to definitely be able to personalize in particular, the knee replacement, but I think at some point it might be the hip replacement too. That'd be my thought.
Yeah, I totally agree with you, Seb. Knee replacements are a gray box. The only way to start to really understand them is to study them by reproducibly putting them somewhere where we deem to be appropriate. And there's only one way to do that is by using a robot to get it more reproducible so you can actually study it. So I would 100% agree with you.
I don't think
Great. I don't
we
think oh, go ahead, Steve.
Sorry, I was just going to say, I don't think we know what we're shooting for yet. And I think one of the big problems in orthopedics is that we don't have really good outcome measures, right? They're also 50 years old, kind of like many of the techniques we're using. And I think that's one of the things that we need in order to differentiate these computer-assisted surgeries and your various alignment strategies from each other and from the old-fashioned way is something better than a Harris hip score and an Oxford knee score
I
to
agree with you.
really
I mean,
understand the differences these make.
I would just plead that like putting in a mechanically aligned knee with manual instruments for everybody the same way every single time can't be as good as personalizing and understanding the knee better with robotics and navigation. I know the data won't show you that, but I think for years we were marred with the idea of using these technologies to put everybody in straight mechanical alignment. And so everyone pointed to navigation and robotics and said it's useless, it doesn't work. Look, all the x-rays are better, but no one does any better. And I think now that we can realize that we can use this technology to personalize, I think the hip is the same thing. I think hip resurfacing and less invasive techniques and maybe not reaming everyone to the medial wall every time, like and personalizing their anatomy for that person. I think that's how we have to think about arthroplasty. We used to think about it as being very reproducing of the same thing that we were taught, the same thing for everybody, and that's what made you a good surgeon. And I think now we're learning that we have to be very good at the technique, but then personalizing it to the patient. And I think really with these technologies that we can start to dial in millimeters and degrees and accuracy, that's the only way you're going to be able to create a personalized hip or knee for that patient.
Great discussion. Thanks. So in the last 20 minutes or so, I'm just going to put the faculty members on the spot. We got a few cases to talk about, all relevant to the excellent talks that we've heard and seen tonight. These are my disclosures. We receive financial support at our institution from many of the vendors whose products we'll talk about. So this is the first case. All these are primary total hip cases. So this is a 67-year-old male, 2-year history of left greater than right groin pain, uses some over-the-counter anti-inflammatories and Tylenol. A fairly healthy guy, but he's had hypertension, had a cardiac stent, a couple of surgeries before, no problems with anesthetic. And when you examine him, he's got a pretty stiff hip, particularly with internal rotation and external rotation. He can still flex. Neurovascular exam is normal, and he's got an antalgic gait, and his Trendelenburg sign is negative. So this is what his hip X-rays look like. Who wants to take
Are
this
you sharing your
case?
screen, Jason, or am I just off?
I'm trying to. Can you guys see it or not?
Yeah, I can see it.
Maybe,
Okay. You might
maybe.
have to stop sharing yours, Seb.
Okay.
Seb just doesn't want to answer the questions.
There we
Okay.
go. There we go.
Okay. Okay. Who wants to go first? The first one. Well, I'll ask everyone's opinion, but so the questions are: how would you treat the patient? What approach? What fixation? What bearing material you're going to use, and any other considerations.
How old is he again?
62,
67.
67.
Yeah.
I'm happy to go first, Jason.
Sure.
So the only other thing I would ask is if he's got any lumbar spine pathology that might contribute. That's all the rage these days. But
Yeah. Good question. Normal back exam and normal imaging of his lumbar spine, no problems.
so I would template him out. It looks like we're going to need a relatively higher offset component, just sort of based on eyeballing this. Looks like he's a fairly big guy with space between his ischium and his lesser trochanter there. But I'm a posterior approach surgeon, so I would do this through a posterior approach. I would do a hybrid hip, so cemented femoral stem, uncemented acetabulum, ceramic on poly with a 36 millimeter head.
Okay. So posterior approach, hybrid hip, cemented femoral stem, cementless shell, ceramic on polyethylene, obviously cross-linked polyethylene. Okay.
I would
All
do the
right.
complete opposite. I would
Okay.
do
Raseb.
I would do bilateral hips in the same setting via an anterior approach using a cementless stem, ceramic head at his age. Um, I'm less concerned about spine issues not being a posterior approach surgeon because the anterior approach surgeons don't believe in the spine issues. Um, and I think, in terms of this case, I agree. I would use a high offset stem, but I'll be perfectly honest, in terms of reproducing his offset completely there, I would give up, a few millimeters of offset and dial in a few millimeters of length, because I'm doing both at the same time. The only reason I would not do that if his other hip was perfectly fine, I want to recreate that anatomy. Um, I would try to recreate his anatomy here, but I'm less fussed about it by lengthening him a smidge more if I need that for soft tissue tension because I'm doing his other side at the same time. I'm going to put in the same size components.
This is why people like you more than me, Seb. You're going to make him taller too.
Yeah, and dudes don't complain ever that you made them a little taller in bilateral hip. I can tell you. I've had zero complaints about that.
Great. Raj, what do you think?
Yeah, I mean, I agree with Seb. I consider myself also an anterior guy, but I do care about spine pathology, even though I am an anterior guy. But a couple things I look at when I look at these X-rays, I look at the femoral canal distally. So, what is that diaphysis? Is it a door A, door B type canal? That'll is there a metaphysis diaphysis mismatch? Will I have to try to open up that distal canal to have a nice fit proximally? Also offset, the higher the offset, the more nervous I get about the replacement to try to recreate it. So things I think about, where am I going to put that cup? I may not, just like Seb had mentioned, may not need to medialize right to the medial wall in this scenario. High offset stem. Trying to recreate some of that offset for the natural tissue tension and agree by doing bilateral. I'm not too concerned about the leg length. I do the first side and then whatever my advanced technology tells me I've gained on the one side, I'll recreate on the other side. Yeah, that's kind of my thoughts.
Thanks, Gavin.
I think everyone's right. Basically, what you've really got to be careful about here is, templating will help you. If you want to go cementless because he looks as though he's got good bone stock, but you're not sure about the metaphyseal diaphyseal mismatch, then templating will really give you an idea as to whatever cementless component you're going to do, whether you're going to be able to achieve that. Um, and if you can't achieve it, then you can always switch to a cemented stem. And then similarly, when you're trying to do the offset, whether you've got the leg length right or not, I would agree. I would probably do bilateral. Um, and then your cut position will really depend on your templating on the femoral side. So if you can get all that, if you cannot get all that offset, regardless of which stem you're using, again, you might not want to ream all the way down, and you want to pick your cut position more carefully. You've certainly got lots of superior acetabular bone stock where you could keep the cup a little bit lateral. So I think everyone's right. They've hit all the points in what you're trying to do for this patient. And I think this is where, when you're templating, it'll actually help you decide what you're going to do intra-op and maybe perhaps change your component in order to establish what you want to achieve. So
Great.
that's what I would do. So I would actually do bilateral hips. I'd go cementless on the acetabular side. I'd want to go ceramic because of his age with highly cross-linked poly. And then I would template. And depending on what my templating would be, I'd either go cementless or cemented. Um, and I wouldn't worry too much about the leg length. But obviously try and put them as close to center of rotation as we can. But if I was going cementless, if it's a case of adding a little bit of length to get that, then that's also fine.
Okay. And your approach?
Posterior every time.
Posterior every time. Great. Okay, good. We got a split there. Obviously, many ways to have a successful outcome. Let's talk a little bit about the bilateral one stage versus stage single procedures. So he's got heart disease, but he's got a cardiac stent. And it sounds like two or three of the faculty are okay with doing bilateral procedures in that setting. What are your contraindications to doing bilateral? Gavin, start with you.
Um, for the most part, I do bilateral if they've got some kind of fixed flexion deformity because if they have one hip, they can't really stand up straight because the other hip has got a fixed flexion deformity, and so they can't rehab properly. So any kind of fixed flexion deformity, I'll go bilateral, unless they're really sick. For most people that are on cardiac stents and blood thinners, as long as the anaesthetist has seen them and the cardiologist has seen them and they're kind of status quo, and that they're stable. I don't really have any contraindication, but if they were a high risk, previous thromboembolism, maybe if they were Jehovah Witness or their starting hemoglobin is already low, that type of thing. When I do bilaterals, I always check with the anaesthetist once I've completed one side to see how the patient is, see what our blood loss has been, how stable the patient is, and if there's any concern with any of those, then I'll say, okay, that's fine. We'll just stop and we'll do one today and we'll bring them back. But I like to do
Okay.
bilaterals. There is a lot of pushback from hospitals and administration because of the cost reimbursement.
Yeah, but saves the system a lot of money in the end. Okay, thanks. Raj, what are your thoughts?
Yeah, I do a
Bilateral
lot of
versus
bilaterals. Some of my contraindications directly to your question would be, as stated, severe anemia, Jehovah's Witness, patients who have severe uncontrolled, cardiac issues, not just a simple stent, if echoes are okay and things like that, they would be fine. And then asymptomatic. So if they're not symptomatic on the one side, just because it's an X-ray showing arthritis, I won't do it. Just stick with whatever symptomatic. So they have to have bilateral hip symptoms in order to for me to do it.
okay, thanks. Steve, anything different?
No, Raj made my point. I don't like talking people into an operation. So if they
Yeah.
say the other side doesn't hurt, then I won't do it.
Okay. And Seb, anything to add?
No, same thing. And I like that about the bilaterals. They have to be able to say, I'm not sure which one I want done first, sort of thing. Those are the people that I usually pick for bilaterals, not just the X-ray.
Gotcha. Okay, so this is the templating. Selected a taper lock stem, a cementless stem, standard offset, and the shell. And we did that through an anterior approach. Commentary, is it reconstructed okay or not? The single side, obviously, he wasn't particularly symptomatic on the right side to the point that has been brought up already, but eventually he's going to come back for that right side, I'm sure.
Yeah, Jason, I like how it looks. I just want to bring up one quick point about choice of implants. I've always been a person that I don't stick with one implant. I think different implants are meant for different types of anatomy. This is a great case of tight distal canal, has a metaphyseal fit, beautiful for something like this kind of type of stem, where it tapers off at the end and it can fit into these type of anatomies very well.
Okay, thanks. Any other comments? We'll move on to the next case.
One screw in the acetabulum, Jason. Is that routine for you or?
It is routine for me. Yeah, I put a screw in every acetabulum. That's partly my fellowship training, and as long as it's good, one good screw. If not, I put two. Okay. Well, in the interest of time here, yeah, let's just basically we've already talked about these points. So this is the second case, 43-year-old female, right hip pain for 2 years. with a long-standing leg length inequality. She had problems as a child, but not much pain until recently, though. She can only walk short distances, though. Her hip is affecting her job. She takes Arthrotech. Past history, she did have a pelvic osteotomy as a child, no other treatment. And on the examiner, she's got a really significant leg length discrepancy, about 4 centimeters short on the right side. She can only flex to about 80 degrees, but she has a fair amount of internal and external rotation with pain and can abduct the hip, but it's somewhat limited. Positive to Nellenberg sign, neurovascular exam normal. And these are her x-rays. So the same kind of questions, approach, fixation, bearing, other considerations. So who wants to go first now? How about Raj?
Sure. Very challenging case. It looks more than 4 centimeters, to be honest with you. Um, these are, just I would pre-op template this exactly, figure out the leg length discrepancy because to me that looks a bit more than 4 centimeters. Um, Questions come into consideration. How much do I want a leg length before I start worrying about sciatic nerve palsies and other such issues? So in this case, I would template it out. I'm suspecting maybe radiographically more than 4 centimeters. So I'm thinking things like subtrochanteric osteotomy may be necessary. Really tight distal canal is expected in these type of dysplastic patients. Try to get the center of rotation on the acetabular side back to the native position. So that's on the acetabular side. There's lots of bone there on the native acetabulum, so I'm not too concerned about getting fixation. On the femoral side again, the big leg length discrepancy, man. So I'm thinking, first of all, subtrochanteric osteotomy. I choose a stem that I can easily achieve that. For example, the S-ROM type stem that could ream distally. I can make a subtroch osteotomy, shorten it down, and then use that. I do use that piece of bone as graft around the osteotomy site. Um, Advanced things beyond that. These are really tough cases. Specifically, these are all nice theoretical things to say, but actually getting that proximal femur down to the native acetabulum is a struggle. So soft tissue releases might be necessary. Some of the abductors, you may need to do some partial releases. These are all technical things, psoas tendon, adductors, all these things play into consideration of soft tissue tensioning in order to get that proximal femur back down. And that's what I would do in ceramic on poly. Small
Okay,
cups.
thanks.
Make sure you have small cups available as well.
Yep, sure. Okay, Steve?
Not much to add. I agree with all of that. Again, my go-to implant is a cemented prosthesis, but for the femur. But I think templating here is key, and making sure you've got kind of plan A, B, C, and the equipment for all of those. Are you going to need an acetabular augment? If you don't have access to assistive technology, being prepared to take an intraoperative X-ray at least to see if you're actually where you think you are in the acetabulum, because it can be surprisingly hard to find the true acetabulum.
Sure. And the cemented implant, like an Exer style stem that you can control the rotation, would be kind of your go-to.
Exactly. When you get the proximal femoral deformity, you can use
Mhm.
something like a modular uncemented stem. But again, I'm familiar with cement. It gives me the ability to control height inversion with that implant. So that's what I use.
Okay, Gavin?
Yeah, the one thing I would add is that I don't think either of the previous guys mentioned what approach. I really think the posterior approach is key for these cases. You can kind of visualize the sciatic nerve. You can kind of track the sciatic nerve from the sciatic notch down, so you can make sure that it's not restricted or caught up in soft tissues. So, because regardless of what you do, I think most likely you're going to need subtroch osteotomy, but you still have to worry about the sciatic nerve. Um, with regards to the other soft tissue releases, I don't find iliopsoas as much a problem. It's already been stretched out because it's up there quite high. But what you can tend to find is that the adductors can often be tight, and they'll often need release through a separate adductor tenotomy towards the end. But my approach to this would be a posterior approach. And then the other bonus of using a posterior approach is when you find that the ilium, it's easy to follow the ilium down the posterior column and follow all the way down towards the ischium and actually find the true acetabulum and the acetabular floor. So it's also very helpful doing it through a posterior approach. I did the lateral approach in some of these cases in my fellowship, and it can be difficult because of the abductors being there and going through that approach. So I'd actually question some of the other guys. Would you actually change your approach? I know there's anterior approach surgeons here. Do you think that the posterior approach is recommended for these types of cases for those reasons?
Actually,
Deb?
so personally,
Mhm.
I do these from the anterior approach. Actually, we have a little case series, and I would say why. I mean, to be honest, you have to strip all the capsule. These become slightly more unstable. So I like the anterior approach for a variety of reasons. One, there's supine on the table. You have fluoroscopy there. My cup is going to be perfect because I can ream it. When you ream these cups, it's soft, crappy, if you can even call it bone. So, every touch ream, you have to be careful. So having an X-ray there to show you exactly where that cup is quite nice. I have a low threshold to use dual mobility in some of these cases. If I'm worried about, if you've had to release quite a bit and you're worried about sort of stability, and it does give you a bit of leeway. Um, Personally, I do a subtrochanteric osteotomy through the anterior approach through a subvastus window. And then in these cases, I've actually found that though I was taught to use an SROM, the Wagner cone actually works pretty well. You can ream through your osteotomy and get good fixation of that distal aspect of the Wagner cone, and then unitize everything. And I like Raj, I use a napkin ring on that. And I gotta say, after I switched from posterior, like the amount of pain, like this person's discharged, in a day and feels so much better despite doing a subtrochanteric osteotomy and taking down, like you have to take down a lot of that tissue up top to get to that acetabulum to dig out that femur. But they do pretty well. And so at least for me, I did these from the posterior approach when I was doing posterior approach, and I appreciate and respect all the ideas of feeling the sciatic nerve, but now you can still feel it actually in the back of the leg. Um, but my preference personally is to do these through the anterior approach. And that's not an easy case, I would say for sure from the anterior approach. If
Yeah.
you're just starting to do the anterior approach, this is not the case to want to do that on. It's probably one of the most complex reconstructions you can do with the anterior approach. So yeah, I wouldn't advocate that, but I think it's very doable and safe.
I mean, for the sake of this talk and what we're doing here today, I think the key is it doesn't matter what approach you use, do something that you're comfortable with. I mean, I've done these through a lateral approach, I can do them just fine. It really the key is you need to be comfortable with your approach. You need to be comfortable with exposure. You need to be comfortable with identifying landmarks. I do highly suggest being comfortable with making sure you can take an intraoperative X-ray just to make sure whether it's anterior, lateral, doesn't matter where you're positioned. I think the key here really is the principles that we talked about and be comfortable with any extensile type of an exposure you're gonna take.
Great. Great feedback. So this is what we did. It's approaching, I guess, 13 years ago. You can see it's the use of the SROM. I did a step cut, shortening subtrochanteric osteotomy. We used the femoral head and screwed that on as an autogenous structural bone graft. Obviously, small shell size. At the time, the bearing that I favored for younger patients was ceramic on ceramic. So that's actually what the patient has. But now I think that would be a ceramic on cross-linked polyathlete. Agreed. Doesn't really matter the approach for me. The posterior approach is extensile, and so that's why I use that. There's one more case. Here's some follow-up just 12 years later. So our last May, you can see how, obviously the osteotomy is united and she's got good long-term performance of this bearing so far. There's one more case we'll just kind of race through because we're down to the last, well, minute or less. So a 32-year-old female, daily left hip pain with limited range of motion. She's on Ozempic and Advil. Perthes disease is a child affecting the left hip, a previous femoral osteotomy and subsequent hardware removal. And her left leg is about 2 centimeters shorter than her right. Posterolateral scar from the previous surgery. She's got obviously limited abduction, limited internal rotation, neurovascular exam, and she's got an antalgic gait. So this was from a couple of years ago. Gavin, you want to take this one?
Thanks, Jason. Yeah, so clearly Perthes disease as a child, she's got short neck, large flat head, kind of incongruent, the short neck. And because of the the failure of growth on that side. You can see there's, the GT, the lesser trochanter are abnormal. There's a big flare of the metaphysis, the bone quality, and the bone is probably underdeveloped on that side, probably as a result of the pain. So it's probably a degree of disuse osteopenia if you compare it to the cortices on the right hip. So you've got all kinds of problems here. First of all, I'd say that the acetabular side is probably going to be the easiest part of this case. There doesn't seem to be really much in the way of acetabular deformity. Even looking at the kind of lateral on the right, on the other side, columns all look reasonable, bone stock looks reasonable. So I think a cementless cup there isn't going to really pose too much in the way of issues. I would like to try and get down to that kind of medial floor. I want to try and recreate some offset here because you can see the lesser trochanter is very close to the ischium. And so you'd be worried about some kind of impingement. So you want to try and restore some offset. You want to try and restore some leg length, just 2 centimeters short on that side. I don't think lengthening or 2 centimeters is really going to be an issue. But you will have to do a full capsulotomy, I think, in order to get that leg length out and the offset. It's been like that for a long time, so it's going to be extremely tight. And then you have to make the neck cut where a normal neck cut would kind of come out. So sometimes what you have to find is you're actually cutting through part of the femoral head whilst doing your neck cut. But then once that's done, you can normally identify the true cortex of the femoral neck, and then you can remove the excess femoral head, which is kind of overlapped down on the neck. She does have a bit of a proximal deformity in that the anatomical axis, there's a kind of a varus type tilt to the proximal third of the femur. And so I think for me, this would be a bit of a challenge trying to get a cementless stem down here because of the metaphyseal diaphyseal mismatch, poor bone quality, um, and that abnormal kind of varus deformity. I don't think you need to do a corrective osteotomy. But for me here, I'd definitely be using a cemented stem. It would give me a lot more versatility for offset, depth of stem insertion, etc., independent of that abnormal poor quality bone as well as the odd metaphysis and kind of mild varus deformity. I still try and template that out to give me a rough idea as to what my offset would be and my corrective leg length. And then doing a trial, once I've got a trial reduction and kind of taking it through that, I'd just be looking for any kind of GT impingement or any other bony impingement, make any fine adjustments to either stem or cut position. And then laterally, sometimes they're really tight again on the adductor muscles and it may require an adductor tenotomy.
Okay, Raj?
I have a series of these as well, but I do this through a DA approach. Last time's the easy side. I agree. In terms of everything that Gavin's already said, I agree with all of that. The lateral is the most important view here for me, just because it's, there's not too much in terms of changes in the femoral shaft and on the lateral. I would start off with a short metaphyseal stem to see if I can get some fixation rotational control. So if I am able to do that and avoid that deformity of the varus, that'd be the first ideal circumstance. If not, then I would switch over as a backup as a cemented stem, which I've done. But I'd have both available. So I would be worried about getting 2 centimeters out. You'd probably get even if you get 18 or 19 millimeters, that'd be extremely happy.
Okay, thanks, Steve.
Well, as you know, I only know how to put one kind of femoral stem in, so mine would be cemented. No surprise there. And I don't know, only know how to put it in through one approach, so it'd be a posterior approach as well.
Okay, yeah, nothing wrong with that. Okay, Seb, anything different?
I think so. I think this speaks to the you talk at the beginning your implant selection, and I would have a low hesitancy to cement this in an elderly person. I think you said she's 30 something. So I like
Yeah.
I like these calcar loading, metaphyseal fitting stems, like an example of the Avenir Complete or the Z1 or the Actis type stem, which are sort of fit and fill, give you good rotational stability, help load the calcar to take away some of the stress because obviously this is crappy bone. This is a case where even with templating, I'd love to have C-arm in there to make sure, my lateralizing enough so that, if I start to get more distal in my stem, I'm not going out that lateral cortex or abutting it. And again, would have a low threshold to change that if I needed to a cemented stem, but my preference would be one of those, HA type coated, the new triple wedges that are sort of coming out from every major company in this case.
Okay, so we've kind of covered that. This is what I did. The cup looks really horizontal there, but I think it's because it's an inlet view on the pelvis. It's not as closed as it might look there. I used a cone type of stem, and there was some rotational and versional abnormality just because of previous osteotomy and hardware removal. So ceramic on poly bearing, cementless shell, and had the advantage of this cone to adjust the version. And we were able to obviously assess the sciatic nerve and the version as well. A question for you: her in her history, she's on Ozempic. What do you tell patients? Obviously, the delayed gastric emptying is a concern about perioperative management. What do you tell patients that are on Ozempic, which is pretty common these days?
Can I take that on?
Yep.
So first of all, as part of the promotion, we're doing a webinar coming up, I think is in April, and where we've got one of the specialists talking on this. I've also got Nelson from Vancouver, and we're going to be talking around GLP-1s, which Ozempic is, and fasting guidelines and dealing with a lot of patients because there's a lot of debate as well as concern as to how to deal with these patients. Do you stop the medications? Do you continue the medications um, in order to proceed safely with surgery? Um, so right now, as part of the standards committee, we're reviewing a lot of the literature on this. So hopefully after this webinar, we can come out with a position statement that will help guide. Um, just to give you a little bit of a kind of a fore on my understanding, having spoken to some of the people who have done a meta-analysis and literature review on this, is that for the most part now, GLPs are injections. They're often weekly. Um, there are some medications which are orally, which they take daily, but they're kind of being superseded by the injections. If you're going to stop these medications, you normally have to stop them at least three half-lives beforehand for it to be any effect. So when you're getting weekly injections or every other week injections, you're going to have to stop at least 3 weeks in advance to have any benefit. But there are problems with stopping some of these medications. So right now, they cause delayed gastric emptying, and that can mean that patients with standard fasting guidelines can still turn up for elective procedures with full stomach contents. And so to try and get around that, some of the recommendations are you don't stop the GLP-1s, but you switch the fasting guidelines to they switch to like a liquid diet 48 hours before. So mashed banana, yogurts, where there's not really any solid foods, so that they can actually try and empty their gut, and then they go back to the standard fasting guidelines, which is kind of no food, clear fluids only, kind of from midnight the night before. Um, then if a patient turns up and they've still got some concerns with full stomach or any kind of regurg, they've sometimes suggested you do an ultrasound at bed, but I don't think that's easy to get. So I think the fasting guidelines, I think, are just acknowledge the fact that people are on GLP-1. Fasting guidelines are probably going to have to change for those individuals. Stopping the medications is fraught with issues and logistic problems. Getting ultrasound scans prior to elective surgery is probably not a good idea. And you might have to consider either cancelling them on the day of surgery, which is never good for um, hospital administration or financial income for any surgeons. So that's kind of where what I've learned in the preparation for this webinar. So look out for the advertisement, look out for the email. We've invited the anaesthetists. We've also invited our bariatric colleagues, orthopedic surgeons to the table on this one. So certainly topical. I'd be interested to hear what some of my colleagues that are on tonight currently do for those patients. But I know that there's definitely mixed messaging going out.
Yeah, there's some Canadian anesthesia guidelines, I think, that are recommend 2 weeks to stop the
Anyone else have a
TLP
problem? Like
wounds.
we have a problem with this at our place because pre-ops are done within a month of surgery. And to your point, some of them might get them 2 weeks or 3 weeks before, and then depending on the anesthetist du jour, they will cite the article du jour saying if they want to do it or don't want to do the case. And I find it exceedingly frustrating given that like 99.9% of our surgeries are done under spinal anyway, and the whole concern of gastric emptying like under general anesthetic, like the reason that all these things are brought up is like historical almost. But despite all that, we don't have consensus, and our anesthetists are very because if 2 half-lives or 3 half-lives, Gavin, it's a huge difference in terms of prep, right? Like three
Yep.
half-lives, if you do your pre-op within a month, you're never going to catch those people in time, versus 2 weeks. And so I think we really need to have a strong COA position on how to manage these. I love the idea of the liquid diet, but even that, like some anesthetists will still say, like if it doesn't move, it doesn't move, be it liquid or solid, right? Or sludge or versus liquid. So. But having a unified front on this, I think, is important because, as you know now, like I don't know, I live in downtown Toronto. Like 30% of my patients are on these medications for either weight loss or
Yeah,
cosmetic reasons.
there's
So it's a huge segment of the population.
yeah. Raj, anything to add?
No, it's generally 2 weeks, and I if I have a anesthetist who I know wants to do a bedside ultrasound, I just try to hide the ultrasound before.
Okay. Dave, anything else?
No.
Okay, great. Well, this is a great session. Thank you. Lots of good discussion, great presentations. I'd like to thank all of our faculty members, Dr. Rodriguez, Dr. Sharma, Dr. Mann, Dr. Wood. I'd like to thank Mary Smith and Megan Corbet from the COA that have helped with the webinar and with the polls. And I'd like to thank all the participants for joining us and remind you that a week from today, we'll have round two, which is going to talk about revision total hip replacements. We'll have a similar format with speakers and some cases at the end. So thanks very much for joining us and have a good rest of your evening.
Thanks, Jason, for organizing.
Yeah, thanks so
You bet.
much.
Thank you.
Guys.
Good night.
Good night.
Right.